Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we'll be continuing in our GU cancer series with a discussion of the evidence base for management of seminoma. In the previous talk, we went over an overview of testicular cancer, and we really focused on seminoma because, as we discussed, although there are many different types of testicular cancer, seminoma accounts for more than 50% of them, and the role of radiation in the management of testicular cancer is predominantly focused on early stage seminomas. And so if you haven't already, I would definitely recommend checking out that overview talk where we go through different types of testicular cancer, talk about the general in terms of workup, staging, and management of seminoma. And then here our evidence will really focus on just stage 1 and 2 seminoma because that is where radiation plays the biggest role. And I'll work on trying to get through this talk without fumbling too much on the word seminoma. Let's start by talking about the management of stage 1 seminoma and the evidence for why we do what we do. So recall that when we talk about stage 1 seminoma, we're really talking about any disease that's confined to the scrotum. It can even be T4 and invading the scrotum, but as long as it's node negative and there's no metastases, it's considered stage 1 disease. So anything that's T1 through 4 and 0 is stage 1 disease. Now, the first order of management for seminoma, recall, is a radical inguinal orchiectomy with high ligation of the spermatic cord. This is very, very important because, again, remember, we do not stick any needles into the scrotum. We are not doing any transscrotal biopsies or transscrotal excisions. The reason for this is that we do not want to seed the scrotum with tumor. And therefore, our approach is inguinal. So it's a radical inguinal orchiectomy with a high ligation of the spermatic cord. And after this initial treatment is done, it's kind of diagnostic because we get pathology, and it's also therapeutic because we take out the cancer. Then any treatment that we do is considered adjuvant treatment, and the goal of this in stage 1 disease is really to minimize the risk of relapse. Now, there are different options when it comes to the management of stage 1 disease. For patients that are healthy and would be compliant, active surveillance is actually the preferred approach because with active surveillance, we know that 80 to 85% of the time, patients are going to be just fine and not have any relapse. 15 to 20% of the time, they might end up having relapse. If it happens, it typically happens within the first 2 to 3 years, and there's very high salvage rates with chemotherapy or radiation initiated at the time of relapse. So as long as patients are good candidates, we can spare them the toxicity of these treatments like radiation or chemotherapy by just surveilling them closely with a history and physical every 4 to 6 months, as well as a CT of the abdomen pelvis every 4 to 6 months for the first 1 to 2 years and then spaced out more thereafter, and then we can avoid treatment. If patients are very nervous about active surveillance, or if they are maybe not good candidates for active surveillance and won't have good follow-up, then we can think about treating them, and we have options there as well. One option is to provide 20 gray radiation to just the para-aortic strip, which is the most common site of recurrence because these nodes are retroperitoneal nodes is where they relapse. So we can radiate the para-aortic strip to a dose of 20 gray in 10 fractions and decrease their risk of relapse to less than 5%. The other option is to do something like carboplatin with an area under the curve of 7 for 1 to 2 cycles, and that similarly will decrease their risk of relapse to less than 5%. So in a nutshell, that's how stage 1 seminoma is managed, right? We either opt for active surveillance up front, or if for some reason we don't do that, then we either do radiation, 20 gray in 10 fractions to the para-aortic strip, or we do carboplatin with an area under the curve of 7 for 1 to 2 cycles. So now that we understand the synopsis of how we manage this, let's get into the evidence base to justify all of this rationale. Most of the data that we have for active surveillance is actually retrospective. And on this slide, I just have a couple of retrospective studies listed that kind of show what to expect after active surveillance for seminoma. So the first is a systematic review of patients with seminomatous germ cell tumors out of Toronto. And these patients were initially treated with an orchiectomy and then surveilled for stage 1 seminoma. What they found is that 17% of patients eventually relapsed, and the majority of relapses occurred within the first year. Only 9% of relapses were more than 2 years out from the time of surgery. And the case-specific survival in these patients was still around 100% because they had very highly effective salvage therapies. There was another retrospective cohort study that was Danish, which showed similar numbers. So 18% of patients in this study had relapse. The median time to relapse, again, was 13.7 months, so around that 1-year mark. 73% of patients had relapse in the first 2 years, 22% years 3 to 5, and then only 4% after year 5. And again, the 15-year disease-specific survival was 99%. The overall survival was 92%. So both of these retrospective studies show that there's somewhere between 15 to 20% relapse rate when patients undergo orchiectomy for stage 1 seminoma and then are managed with active surveillance. And because we have very effective salvage therapies, so either chemotherapy or radiation initiated at the time of recurrence, we still see very excellent disease-specific survival as well as overall survival in these patients. Although overall there's a lack of prospective data, there is one small study out of Sunnybrook that prospectively looked at surveillance followed by salvage treatment for stage 1 seminoma patients. It was a prospective single-arm study, only 88 patients, but they found that the 10 and 15-year actuarial relapse-free rate was 80%. So out of the 88 patients on the study, only 17 patients had a relapse, and 15 out of 17 of these relapses were located below the diaphragm. The patients that did have a relapse were then treated with salvage radiation or salvage chemotherapy at the time of relapse. Most of the patients underwent salvage radiation, and of the 14 that got salvage radiation, only one ended up having another relapse requiring salvage chemo. And then a minority of the patients, 3 out of the 17 that had relapse, ended up getting chemotherapy. So the takeaway from this prospective data as well is that stage 1 seminoma can be safely treated with surveillance after orchiectomy. And we really think about reserving radiation or chemotherapy in the case of salvage treatment that's needed for relapses. And if we do kind of utilize this active surveillance followed by salvage treatment approach, patients still have very excellent outcomes, a little bit of prospective data to support this as well. And you can imagine if you were in the shoes of a 20-something-year-old male diagnosed with a seminoma, and it was stage 1, they underwent orchiectomy. If 80 to 85% of the time they could avoid any further treatment in their lifetime, that would definitely, I think, be the way that you'd want to be treated. So active surveillance is our choice of treatment for stage 1 seminomas. Of course, even though most of these patients are going to go on active surveillance with stage 1 seminoma, we still need to know for board exams and on the off chance that we do need to treat these patients for whatever reason, we still need to understand the evidence for how we would manage a stage 1 seminoma patient if we were to manage them with definitive radiation or chemotherapy and the evidence for this. So there are a series of trials from the MRC, which is the Medical Research Council Testicular Tumor Working Group, and they are called MRC TE with a number at the end. So MRC TE10 was a trial that helped us to establish the best radiation field for patients with stage 1 seminoma. So this trial enrolled just under 500 patients with stage 1 seminoma, and they really only had T1 to T3 cancers. And after undergoing orchiectomy, these patients were randomized to radiation. The dose was 30 gray in 15 fractions, and they were either treated to a dogleg field, which included the para-aortics as well as ipsilateral iliac lymph nodes, or just to the para-aortic strip, which was a field ranging from T11 to L5. So remember, this was done in a 3D era. This was done in the early 90s. And so the para-aortics included, and we went through the borders of these fields beforehand as well, but the para-aortics span from T11 to L5, and then if we were chasing the dogleg, meaning the ipsilateral iliac nodes, the field was extended down almost like half of an upside down Y, including the ipsilateral pelvis. So the dose was 30 gray and 15 fractions, and it was a dogleg field versus a para-aortic strip. What they found is that there was no significant difference in the 3-year recurrence-free survival or overall survival based on the field that was used. So in both arms, the recurrence-free survival was around 96%. The 3-year overall survival was 100% with dogleg versus 99% with the para-aortic strip, not significantly different. The pelvic relapse was very minimal, so only 4 patients in the group that got para-aortic strip radiation had a pelvic relapse, amounting to 2% of patients versus 0% of patients in the dogleg group. But importantly, the patients that got treated to the smaller field had less acute toxicity, so they had less nausea and vomiting, diarrhea, as well as leukopenia, and they also had higher sperm count. So if you look at the azoospermia rates, azoospermia is the absence of sperm in the ejaculate, and with the dogleg field, it was 35% azoospermia versus only 11% with the para-aortic strip. So the big takeaway here from MRC TE10 is that treating the para-aortic strip, so that means T11 to L5, should be considered standard for stage 1 seminoma. And if we compared treating a dogleg field, the para-aortic strip improves toxicity without any significant differences in recurrence-free survival or overall survival. There might be a very small increase in the rate of pelvic relapse, but this does not translate to any compromise in, again, their recurrence-free survival or their overall survival. And so the para-aortic strip is the standard of care for stage 1 seminoma for adjuvant treatment after orchiectomy. Okay, so now we've established the field that we're treating. MRC TE10 helped us decrease the field that we needed to treat for stage 1 seminoma, and instead of a dogleg, we now realize that we can do a para-aortic strip without compromising outcomes and by improving toxicity. So para-aortic strip is the field that we treat, ranging from T11 to L5 for stage 1 seminoma. Now, what is the appropriate dose? So in TE10, they were still using a dose of 30 gray and 15 fractions. The MRC TE18 trial randomized patients to 30 gray versus 20 gray of radiation and actually helped us decrease the dose that we're using as well. So this trial ran later on in the 90s, in the late 90s, and it randomized patients with stage 1 seminoma after orchiectomy to either 30 gray and 15 fractions to T11 to L5 or 20 gray and 10 fractions to T11 to L5. And it was designed as a non-inferiority trial, powered to exclude more than a 4% difference in the 2-year relapse rates. Their results showed no significant difference in the 2-year overall survival or the recurrence-free survival. So they found 10 relapses in the 30 gray arm compared to 11 relapses in the 20 gray arm, and their 2-year recurrence-free survival was 97% in both arms, and it was not significantly different. Importantly, with a decreased radiation dose, the 20 gray arm, they actually found improved toxicity profile and less acute side effects. So patients that were treated with 20 gray had less moderate to severe fatigue. They had improved ability to conduct their normal work at 4 weeks out from radiation, and they mostly returned to baseline by about 12 weeks in both arms. So if you look in the table, their rates of lethargy were 20% with the 30 gray arm versus only 5% with the 20 gray arm. And their inability to conduct normal work was 46% with the 30 gray arm versus 28% with the 20 gray arm. So significant improvements in their toxicity profile, no significant difference in their recurrence-free survival. And interestingly, of the patients that were treated in this trial, 6 of them ended up having a second primary cancer diagnosed, and all of them occurred in the 30 gray arm. So the conclusion from MRC TE18 is that 20 gray is non-inferior to 30 gray and 15 fractions for stage 1 seminoma as an adjuvant treatment. And in fact, 20 gray is actually associated with improved acute toxicity profile. So MRC TE10 helped us to decrease the size of the field that we're treating, and then MRC TE18 helped us to decrease the dose of radiation that we're giving. And so the standard adjuvant treatment, if we're giving radiation for a stage 1 seminoma after radical orchiectomy, is 20 gray and 10 fractions to the para-aortic strip, which ranges from T11 to L5. So if you need a little mnemonic to remember these, think TE10 told us where our field will end. So TE10 told us that we're only treating the para-aortic strip, T11 to L5. And then TE18 gave us what dose we need. So 20 gray and 10 fractions is non-inferior to 30 gray and 15 fractions. So TE10 told us where our field will end. TE18 gave us what dose we need. So that's a little mnemonic to remember those two trials if you need. The last MRC trial in this stage 1 section is MRC TE19, which compared carboplatin versus radiation. So this trial enrolled just under 1,500 patients with stage 1 seminoma who had undergone orchiectomy and randomized them to either carboplatin with an area under the curve of 7 given for 2 cycles every 3 weeks versus radiation. And many of these patients that got radiation were then enrolled on TE18, where they were randomized to 20 gray versus 30 gray to the para-aortic strip. So the 2 arms on MRC TE19 were carboplatin AUC 7 for 2 cycles given 3 weeks apart, or radiation. And they found no significant difference in the 2-year recurrence-free survival between the arms. So the 2-year recurrence-free survival was 98% in the carboplatin group versus 97% with the radiation group. And at 5 years, it was 95 versus 96%. So high 90% recurrence-free survival. No significant difference with chemo versus with radiation. They found that a greater dose of carboplatin was associated with improved recurrence-free survival, and they found that the recurrence-free survival was 96% if they received greater than 99% area under the curve of 7 versus 92% if otherwise. The carboplatin arm actually had more para-aortic relapses, but they had fewer pelvic or mediastinal or supraclavicular relapses versus radiation. And there's another kind of pooled analysis that we'll look at too with patterns of relapse, but that does seem to be the case that with radiation, we're treating the para-aortic strip, so these patients don't recur in the para-aortic strip. And if they do recur, they tend to recur elsewhere, so pelvis, mediastinum, or supraclavicular field. Other than patterns of relapse, the other important piece that came out of TE19 was a comparison of the toxicity profiles of carboplatin versus radiation. And it turned out that overall, carboplatin seemed to be associated with fewer acute side effects, so less acute dyspepsia, less lethargy, as well as inability to do normal work, but there were higher rates of thrombocytopenia with carboplatin compared to radiation. So different toxicity profiles for these two treatments. Also, as you might imagine, carboplatin actually reduced the risk of developing a contralateral germ cell tumor. The risk was 2% with carboplatin versus 15% with radiation. So the big takeaway from MRC TE19 is that carboplatin with an area under the curve of 7 given for 2 cycles is non-inferior to radiation for stage 1 seminoma. And it's important to keep in mind the different toxicity side effects in terms of carboplatin versus radiation, as well as the fact that carboplatin seemed to lower the rate of developing a contralateral germ cell tumor as well. And then finally, if you need a mnemonic for TE19, this is not a great one, but I just remember carbo19 for some reason in my head. So TE10 is where our field ends, TE18 is what dose of radiation we need, and then TE19, I just remember carbo19, and that helps me remember that it randomized patients to carboplatin versus radiation. Just to reiterate the patterns of relapse after various treatments, there was a TE pooled analysis that looked at all of the patients that were treated on TE10, 18, and 19. And overall, they found that the case-specific survival was excellent. It was 99.8%, with only 98 relapses overall out of over 3,000 patients that were treated on the trial. So almost 100%, but not quite, case-specific survival. And of all of the relapses, only 0.2% of them actually occurred after 3 years. And the site of failure really corresponded to where the treatment was. So as you can imagine, in the carboplatin arm, most of the failures, 2/3 of failures, were in the retroperitoneal area, which makes sense, right? Because with carboplatin, you're giving systemic therapy, so you're overall reducing the risk of recurrence. But location-wise, if these cancers recur, they're most likely to come back in the retroperitoneum. If we radiate the retroperitoneum, which we do in the para-aortic strip radiation, or if we're giving dogleg field radiation, they're not going to recur in the retroperitoneum, and that's exactly what we see. So with para-aortic strip radiation, we see about 37% of failures in the pelvis, about 26% of failures in the mediastinum or the neck. So most of the failures are either above or below the para-aortic strip. And then if we radiate the pelvis as well with the dogleg field, then 2/3 of failures happen in the mediastinum or neck. So once again, reiterating that wherever we treat, with radiation, we drive the local relapse there down, or rather the regional risk of relapse. So if we treat the retroperitoneum, we do not expect them to relapse in the retroperitoneum. But if we don't localize our radiation there, or if we give carboplatin, then we would expect a relapse there. So these cancers are most likely to come back first in the retroperitoneum, then in the pelvis, and then in the mediastinum or neck. So that's an important point about just how these cancers do tend to relapse if they recur. So just to summarize, here are some of the major takeaways from everything that we have talked about in regards to stage 1 seminoma, starting with a summary of the evidence. So we presented a couple of retrospective reviews, one out of Toronto, one Danish retrospective review, and then that small Sunnybrook prospective study. And they all showed the same thing, right? There's about a 15 to 20% risk of relapse for patients that have stage 1 seminoma that then undergo orchiectomy followed by active surveillance. So the relapse-free survival is around 80 to 85%. And that really justifies this method of active surveillance for patients that are able and willing to kind of be closely followed with Q 4 to 6 months CT imaging as well as history and physical. If we can follow these patients, we can spare about 80 to 85% of them from needing any kind of salvage therapy. And in the event that they do recur, we can then treat them with chemotherapy or radiation at that time and not compromise their overall survival or case-specific survival. So very good outcomes with active surveillance, allows you to spare more than 80% of your patients from any further treatment. And that's kind of the preferred modality whenever possible is active surveillance. And we have both retrospective as well as a little bit of prospective data for this. If we are treating patients with stage 1 seminoma, the MRC TE10, 18, and 19 trials provide us with a lot of guidance on what exactly to do. So remember the mnemonic, MRC TE10 tells us where our field will end, TE18 tells us what dose we need, and TE19, just remember carbo-19. So TE10 compared a para-aortic strip versus treating a dogleg field, which includes the ipsilateral pelvis, and found that treating the para-aortic strip was non-inferior to the dogleg field, and it improved toxicity. TE18 compared 20 gray versus 30 gray and actually showed that 20 gray was non-inferior and also had better toxicity outcomes. And then finally, TE19 compared carboplatin for 2 cycles. Dose was area under the curve of 7 and found that this was non-inferior to radiation. So that was TE10, 18, and 19, which are the most important trials to know in the stage 1 seminoma patients. And then finally, from all of these trials, there was a pooled analysis looking at patterns of relapse. And we found, as expected, that if we radiate the retroperitoneal region, we're going to decrease our risk of recurrence in the retroperitoneum. So if you get para-aortic strip radiation, you're more likely to have either pelvic or mediastinal and neck relapses because we've treated that first echelon of where the cancer is most likely to spread to. If you get chemotherapy, you're more likely to have a retroperitoneal relapse just because chemotherapy is a systemic treatment that systemically drives your rate of recurrence down, but it doesn't alter where it's most likely to drain. If it recurs, it's still most likely to recur in the retroperitoneum. And just because I'm a little bit of a visual person, here's kind of a tree diagram of how we can think about managing patients with stage 1 seminoma. So the first step is inguinal orchiectomy with a high ligation, and our preferred treatment is active surveillance, although we can consider radiation 20 gray in 10 fractions to the para-aortic strip, which remember spans from T11 to L5, or we can consider carboplatin, AUC7, for 1 to 2 cycles. If we pursue active surveillance, the majority are not going to recur, but maybe 10 to 15% of patients may have a relapse. And when it recurs, it's most commonly a para-aortic relapse. And in the event that it does recur, it is then managed as a stage 2 because we now have para-aortic nodes present, right? And so I think this then serves as a nice segue into how we think about managing stage 2 seminoma. And you can already see from the boxes at the bottom of the screen that we're starting to think about higher doses, right? We're doing 20 gray, we're doing a dogleg field, so a larger field now, and we're thinking about boosting the nodes. So 30 gray to nodes that are less than 2 centimeters, or 36 gray if they're 2 to 3 centimeters. And then for nodes that are even larger than 3 centimeters, the preferred treatment really is chemotherapy. And there's a little bit of data, which we'll talk about as well, for a retroperitoneal lymph node dissection. So I think this sets the stage nicely then to get into some of the evidence for management of stage 2 seminoma. With stage 2 seminoma, the treatment paradigm is a little bit more aggressive, whether we are thinking about radiation or whether we're thinking about chemotherapy. Just like with stage 1 seminoma, both radiation and chemotherapy are options. But active surveillance is really not an option anymore because now the risk of recurrence is higher. So when we think about radiation, with stage 1, we were talking about radiating just the para-aortic strip. With stage 2 disease, we still generally give radiation to a dogleg field. So that includes the para-aortic strip as well as the ipsilateral iliac lymph nodes. And we treat that entire field to a dose of 20 gray, and we actually boost any involved nodes to 30 to 36 gray. So 2A disease, which is nodes that are measuring less than 2 centimeters, we routinely will treat with 30 gray. For stage 2B disease, which is nodes that are measuring more than 2 centimeters, we think about giving these nodes 36 gray. And then the chemotherapy option is to give either EP, a regimen called EP, which is etoposide and cisplatin, or BEP, which is bleomycin, etoposide, and cisplatin. EP is given for 3 cycles, BEP is given for 4 cycles. But again, we're giving more chemotherapy. We're not just giving 1 drug, we're giving 2 to 3 drugs. So more aggressive, whether you're doing radiation alone or whether you're doing chemotherapy alone. Now, for nodes that measure greater than 3 centimeters, so this is like higher stage 2B or 2C disease. 2C is when nodes measure more than 5 centimeters. So definitely for 2C and then stage 3 to 4 disease, upfront chemotherapy is the preferred option. And even for stage 2B disease, when it's measuring more than 3 centimeters, generally it's preferred to give chemotherapy over radiation because now the nodes are quite large and they're at a higher risk for distant metastasis. So that's kind of in a nutshell the treatment paradigm for stage 2, but let's get into the evidence. The study for our field that we use to treat stage 2 seminoma comes from Germany, and it's actually a prospective study. So it's not a randomized study, but it's a prospective study of a modified dogleg field for patients with stage 2A/2B seminoma. So this trial ran in the early 90s and enrolled 94 patients with stage 2A to 2B disease. So remember, 2A is lymph nodes that are measuring less than 2 centimeters, and 2B is lymph nodes that are 2 to 5 centimeters. These patients were treated with a modified dogleg field as opposed to the inverted Y field, which was previously the standard. So for the para-aortic strip, it was the same thing. They went from T11 to L5. And then from the transverse process of L4, they went to the top of the acetabulum, sort of diagonally, to cover the ipsilateral iliac lymph nodes. So as opposed to the inverted Y, which would have covered the pelvis bilaterally, they were only covering the ipsilateral pelvis. So you're still getting the para-aortic strip, but then you're also getting the ipsilateral pelvis now. And so that's the modified dogleg field. The doses that they used were 30 gray and 15 fractions for stage 2A disease versus 36 gray and 18 fractions for stage 2B disease. So 2 gray per fraction, 3 extra fractions if it's a little bit of a larger node, so stage 2B. And in the modern era, we're typically treating the dogleg field to 20 gray and just boosting the involved nodes. At this time, they were uniformly treating the entire field to 30 to 36 gray. The 6-year relapse-free survival in this study was 95% for stage 2A and 89% for stage 2B. And in terms of toxicity, they found 8% rate of grade 3 nausea for stage 2A patients versus 10% grade 3 nausea for stage 2B patients. So the takeaway from this German prospective trial is that stage 2 seminoma, stage 2A to B seminoma, can be safely treated with a reduced field of radiation, so modified dogleg rather than the inverted Y. And the benefit of this is that it helps improve the toxicity a little bit and also decreases risk of secondary malignancy in the contralateral pelvis. So that was our trial looking at radiation and the appropriate field for radiation. There's another prospective observation study that's a Spanish study that looked at chemotherapy for patients with stage 2A and B tumors that had undergone orchiectomy. So in this Spanish study, they were allowed 2 different choices of chemotherapy, so either EP times 4 cycles, so EP is etoposide and cisplatin, or BEP times 3 cycles, which is bleomycin, etoposide, and cisplatin. And the way I remember this is with BEP, you have more drugs, so you're adding the bleomycin, so you give 1 less cycle, which is 3 cycles. If you're omitting the bleomycin and just doing the 2 drugs, EP, then you give 4 cycles. So it's either EP times 4 or BEP times 3. And the table here kind of compares the results from the German study looking at modified dogleg radiation versus the outcomes from this Spanish study looking at EP times 4 or BEP times 3. And what this essentially shows is that the chemotherapy regimens were equivalent in terms of the 5-year progression-free survival and overall survival, and also tolerable in terms of toxicity. So I shouldn't use the term equivalent because it's not like this was a randomized study that was powered for equivalence or anything like that. We are comparing 2 separate prospective cohort studies and kind of just bird's eye view comparing the outcomes between these studies. So it's not the same as a randomized study by any means, but they essentially show very, very comparable outcomes. So recurrence-free survival, high 90% range for stage 2A versus high 80% range for stage 2B, and that's for both the radiation versus chemotherapy. And disease-specific survival is, again, very high 90s to 100% across all of the different regimens, as well as 2A versus 2B. So the big takeaway here is that EP times 4 or BEP times 3 is another well-tolerated and effective regimen, and it can serve as an effective alternative to dogleg radiation. And so this is where we get our 2 main treatment paradigms from. So either dogleg radiation up to 30 to 36 gray, depending on the size of the lymph node, or chemotherapy with EP times 4 or BEP times 3. There are some ongoing efforts in the modern era towards further de-escalating therapy. So the SAC-01 and 10 trial was a single-arm phase 2 study of patients with stage 2A and B seminoma that were treated with just carboplatin AUC7 for one cycle, followed by involved nodal radiation to 30 to 36 gray. So they're giving less chemo, right? Instead of EP or BEP, they're giving just carboplatin AUC7 times one cycle, the way you might for a stage 1 seminoma. And then instead of treating the whole modified dogleg field, they're treating involved nodal radiation to 30 to 36 gray. And the target of this study was to show a 3-year progression-free survival of 95%. And unfortunately, this study target was not met. So the 3-year progression-free survival on the study was just a little bit under. It was 93.7%. But you can imagine they showed low rates of grade 3 to 4 toxicity because we're treating a much smaller target now and we're giving less chemo as well. So this was technically a negative single-arm phase 2 study. But then there is an ongoing SAC-01-18 study, which is looking at 2 different cohorts. So cohort 1 is of primary stage 2A patients or recurrent stage 2A seminoma after having undergone active surveillance for stage 1. And these patients are being treated with one cycle of carboplatin AUC7 followed by 24 gray in 12 fractions involved nodal radiation after 3 weeks. So that is stage 2A seminoma with nodes that are 2 centimeters or smaller. They're looking at one cycle of carboplatin followed by 24 gray in 12 fractions involved nodal radiation. And then cohort 2 is stage 2B. So it's either primary stage 2B or recurrent stage 2B after undergoing active surveillance for stage 1. And they are getting treated with one cycle of EP followed by 30 gray and 15 fractions involved nodal radiation after 3 weeks. So this study will be interesting to follow and see if we can get away with less chemo, lower doses of radiation, and involved nodal radiation rather than involved field radiation, which is what we were doing with the modified dogleg radiation. So this will definitely be interesting to follow, and we will await the results. For now, though, our field and dose for stage 2 seminoma is what we've discussed, which is 20 gray and 10 fractions to a modified dogleg field, and then we cone down and boost any involved nodes. So if it's stage 2A and the nodes are 2 centimeters or smaller, we boost to 30 gray. If the nodes are 2 to 3 centimeters, we boost to 36 gray. And for anything that is greater than 3 centimeters, so larger nodes, or if it's even more than that, if it's greater than 5 centimeters and classified as a stage 2C, these patients we should really think about treating with chemotherapy rather than upfront radiation. The last trial that I want to mention in this talk on the evidence base for seminoma is the SEMS trial, which is a phase 2 study looking at retroperitoneal lymph node dissection. So this was a prospective phase 2 study looking at surgery for what they called early metastatic seminoma, which is stage 2, or in other words, node-positive seminoma. And this trial took 55 patients with stage 2 seminoma with lymph nodes measuring 1 to 3 centimeters and treated them with open retroperitoneal lymph node dissection. They found that 16% were pathologic node negative, 22% were N1, 56% N2, and 5% N3. And the 2-year recurrence-free survival for these patients was 81% with a recurrence rate of 22%. And any recurrences were then treated with either chemotherapy in most of the cases or additional surgery. And they reported low toxicity rates as well. So 4 patients that had acute grade 1 to 3 complications and 4 patients that had late complications 30 days out. So this is just to show that retroperitoneal lymph node dissection may be an option for patients with stage 2 seminoma that have clinically low volume retroperitoneal nodes. So that's 1 to 2 nodes that are measuring less than or equal to 3 centimeters. But the caveats of this are that there's short-term follow-up to the study. Surgeries were performed at pretty high volume centers, so this may not be applicable across the board. Again, I think use of lymph node dissection in this setting is really going to be institution dependent, and practice patterns might vary, but it's good to know that this is an option and that there is data for it, prospective data for it. Let's end by summarizing some of the major takeaways, starting with a summary of the evidence for the stage 2 seminoma trials that we just talked about. So we first talked about the German prospective study that looked at dogleg radiation as opposed to the historical standard, which was inverted Y field. And they treated anything that was stage 2A, meaning nodes measuring 2 centimeters or less, to a dose of 30 gray. And they treated anything that had greater than 2 centimeter nodes to a dose of 36 gray. So stage 2B was treated with 36 gray. And this was just a single arm prospective study, but it showed reasonable outcomes. And so we have moved towards modified dogleg radiation rather than the inverted Y field where we treat the bilateral pelvis. The Spanish study is where we get the paradigm of EP times 4 or BEP times 3. So chemotherapy in lieu of radiation for management of stage 2 seminoma. And remember, if nodes are on the larger side, so if they're greater than 3 centimeters, then typically chemotherapy is actually preferred. We then talked about the SEMS trial, which is a phase 2 trial that still has short follow-up, but it presents retroperitoneal lymph node dissection as a possible option for the management of stage 2 disease. And then we also mentioned the ongoing SACA-118 trial that's looking at de-escalation of chemo and radiotherapy for stage 2 disease. So if it's stage 2A, they're looking at carboplatin for 1 cycle, followed by 24 gray involved nodal radiation, so just treating the nodes rather than the whole field. And then for stage 2B, they're giving EP followed by 30 gray, again, involved nodal radiation rather than treating the whole field. So that will certainly be interesting to follow. So once again, if you're a visual person, here's a little tree diagram of the different management options. And keep in mind that this applies to stage 2A and 2B seminoma. And this also applies for relapsed stage 1 seminoma, because once it relapses, and most likely if it relapses, it's going to come back in the para-aortic lymph node, so the retroperitoneal region. And at that point, we would treat it the way we would treat a stage 2A or B seminoma. So the first step is always inguinal orchiectomy with high ligation. If it's a primary seminoma, and if it's a relapse seminoma, they've already had that done. And then the treatment options are dogleg radiation, and we prefer the nodes to be less than or equal to 3 centimeters if we're going to pursue that option of dogleg radiation. So we treat 20 gray to the modified dogleg field, give a 30 gray boost, so to a total of 30 gray, so 10 gray boost to nodes that are measuring 2 centimeters or less, a 16 gray boost for a total of 36 gray to nodes that are measuring 2 to 3 centimeters. Another option is chemotherapy with EP times 4 or BEP times 3. And for larger nodes, we tend to prefer chemotherapy. And then finally, we have a little bit of data, although not long follow-up, but the SEMS trial for retroperitoneal lymph node dissection. And again, for stage 2C, so very large nodes measuring over 5 centimeters, or stage 3 disease, we really prefer chemotherapy up front, so EP times 4 or BEP times 3, and then we save radiation or surgery for salvage options. This table is taken from the overview lecture, and it kind of reiterates the same treatment paradigms that we've talked about. I think the key thing to keep in mind for seminoma is that it has such an excellent prognosis, so excellent that we don't even group anything as a stage 4. Even if there's metastatic disease, it's considered stage 3 for seminoma. And that's because these patients do so well. And so when we have such excellent prognosis and high rates of survival, it's especially important to keep in mind the toxicities of various treatments that we're using and try to minimize toxicity as much as possible, because these patients have a long time to live and we want to maintain their quality of life. So remember, with seminoma, the initial treatment is always radical inguinal orchiectomy with high ligation, and then the subsequent strategy is kind of tailored to stage. Stage 1, the preferred option is active surveillance, and when we think about giving any adjuvant radiotherapy, the biggest role of radiation is really in the management of stage 1 disease or stage 2A to 2B disease. Once we're dealing with bulky lymph nodes that are greater than 3 centimeters in size, the preferred option really is to pursue upfront chemotherapy and reserve radiation or surgery for salvage. So I hope that this table kind of nicely summarizes everything that we've gone through, and hopefully our discussion of the evidence helped kind of put things into perspective and understand exactly why we do what we do when it comes to seminoma. That brings us to an end, and thank you so much for your time and attention.